Welcome to the Deep Dive, where we take your sources, unpack complex topics, and help you get informed fast.
Think of us as your guides, navigating the intricate landscapes laid out in the material you share with us. We're here to find the crucial points, connect the dots, and, well, give you that depth of understanding you're looking for.
Absolutely. And today we are embarking on a truly deep dive. Our subject, the incredible anatomy of the arm, and zooming in, the vital area known as the cubital fossa. We've got a single source document today, but it's packed a detailed map, really, of this region.
It really is. It's a comprehensive look, almost challenging us, to master the information. Our mission is to navigate this map together, identifying the key landmarks, tracing the pathways of nerves and vessels, understanding the muscles that power movement.
And crucially, seeing why these anatomical details matter, especially from a clinical perspective,
Yeah.
that practical application.
Exactly. That's where the real understanding comes in.
That's the goal. We're going to go through this systematically, piece by piece, ensuring we cover every concept, every structure, every detail provided in this text. The idea isn't just to gloss over it, it's to really build that solid foundation, to understand this anatomy at a level that feels like true mastery.
Yeah, to really own this knowledge. So consider this our expedition into the brachium. Let's unpack this.
All right, so our map of the arm begins with defining the territory. Where exactly are we focusing when we say the arm in anatomical terms?
Good starting point. Anatomically, the arm, or the brachium as the source calls it, isn't the whole upper limb. It's specifically the region between the shoulder joint and the elbow joint. That's the segment we're exploring today.
Right, just that section. And providing the structure for this region is just one bone, acting as the central pillar.
That's the humerus. It's the sole bone of the arm, running the full length from shoulder to elbow, serving as the attachment point and support for pretty much everything else.
Now, one of the first big concepts our source emphasizes is that this area isn't just an undifferentiated cylinder. It's organized into distinct spaces.
Precisely. The arm is fundamentally divided into compartments. An anterior compartment, which is predominantly focused on flexion, bending things.
Bending the elbow, flexing the shoulder.
Exactly. And then there's the posterior compartment dedicated to extension, straightening things out.
And what creates these internal divisions? How does that separation happen?
That's the work of the medial and lateral intermuscular septa. Think of these as strong fibrous sheets, almost like internal walls. They're extensions of the deep fascia, that tough, stocking-like layer around the muscles.
Right, the fascia.
And these septa attach right onto the humerus and stretch outwards to the deep fascia, effectively carving the arm into these separate anterior and posterior spaces.
So they're not just dividers. They have other functions.
Oh, definitely not just dividers. Their function is crucial. By separating muscle groups, they allow muscles in one compartment to act, relatively independently from those in the other, preventing interference. They also provide additional surfaces for muscle attachment, which is important for power and leverage.
Makes sense. More surface area for muscles.
Exactly. And importantly, they create these sort of planes along which nerves and blood vessels travel. They often define the pathways these structures take through the limb.
Fascinating, like predefined routes within the anatomy. That's a really helpful way to think about it.
It is. And the source points out these septa are particularly robust and well-defined in the lower half of the arm, where they attach firmly to the medial and lateral borders and the supracondylar ridges of the humerus. They get thicker down there.
Speaking of the lower arm, the cubital fossa is also a big part of today's dive. How does that relate to the arm itself?
Ah, the cubital fossa. That's that triangular hollow right at the front of the elbow. It's integral to understanding the arm because many of the major structures will discuss nerves, arteries, tendons. They don't just stop at the elbow joint line.
They keep going.
Right. They pass through the cubital fossa to enter the forearm. So it's the essential transition zone, the junction box, if you will.
Okay, so we have the bone, the compartments, and the key transition zone. The source also uses the formal term brachium for the arm.
Right. Brachium. And you'll notice how this influences the naming of many structures here. The brachialis muscle, the coracobrachialis muscle, the brachial artery. It's a linguistic clue to their location and primary association with the arm itself.
Okay, good to keep that term in mind. With that framework set, let's talk about finding our way on a living person. The source lists surface landmarks. Why is being able to feel or see these important for, say, someone aiming for that elite professional level of understanding?
Oh, this is absolutely fundamental clinical skill. Before any advanced imaging or testing, palpation, feeling things, and visual inspection using these surface landmarks guides your whole examination. It helps you locate underlying structures, assess for swelling, tenderness, or deformity.
It's your first pass.
Exactly. It helps narrow down potential diagnoses. It's really the starting point of any physical assessment of the arm. You have to know what you're feeling for.
Makes sense. So let's navigate some of these landmarks. First up, the greater tubercle of the humerus.
Okay, the greater tubercle, that's the prominent bony point you can feel on the lateral side of the shoulder, just below the acromion process. That's the bony tip of your shoulder blade you can feel right at the top.
Gotcha.
With the arm hanging by your side, the deltoid muscle covers it, but you can often palpate the tubercle deep to it, especially if you relax the deltoid. It's the most lateral, bony bit up there.
Okay. What about the shaft of the humerus itself? Can you feel much of that?
The shaft is mostly covered by thick muscles, so it's hard to feel distinctly, especially higher up where the deltoid and pectoralis major wrap around it. Lower down, it's deep to the biceps and brachialis in front and the triceps behind. So not super easy to palpate directly along its length.
Moving down to the elbow then,
Yeah,
the medial epicondyle.
this one is very easy to find. It's that large, prominent, bony bump on the medial side, the inside of your elbow. You can feel and often see it clearly, particularly when your elbow is partially bent. It sticks right out.
Yeah, that one's obvious. And its counterpart, the lateral epicondyle.
That's on the lateral side, the outside of the elbow. It's less prominent than the medial one, definitely. You can usually feel it in a slight depression on the back and side of the elbow, especially when your arm is straight in extension.
Okay. Extending upwards from those, the medial and lateral supracondylar ridges.
Right, these are essentially the lower edges of the humerus shaft, just above the epicondyles. You can feel these bony ridges running upwards in the lower quarter of the arm, tracing them up from the epicondyles. They get sort of better defined as they approach the epicondyles themselves.
Got it. The deltoid muscle is next on the list. We mentioned it covering the greater tubercle.
Yep, the deltoid. That's the muscle that forms the rounded contour of your shoulder, gives it that cap shape. The source reminds us its lower pointed part, its apex, attaches to the deltoid tuberosity, which is a roughened area kind of on the middle of the outer front surface of the humerus shaft.
Coraca brachialis, you mentioned that earlier.
The coraca brachialis, yeah. This muscle is less obvious on the surface, but you can sometimes feel it as a subtle rounded ridge high up on the medial side of the arm, the inside.
And the source pointed out something clinically relevant here.
Yes, a crucial clinical insight mentioned in the source. The brachial artery pulsations can often be felt in the depression behind this muscle in the upper arm. That's a handy spot for a pulse check if you're maybe not near the wrist or elbow, or if those pulses are hard to find. Good alternative spot.
Good tip. Now, the biceps brachii, the muscle most people immediately associate with the arm, the show muscle.
Exactly. It's very conspicuous. In the upper arm, it's overlapped a bit by the pectoralis major and deltoid. But lower down, it forms that noticeable bulge on the front of the arm. It becomes very firm and prominent when you flex your elbow against resistance, make a muscle.
And its tendon is a landmark in itself, right? Down at the elbow.
Absolutely. You can feel the strong cord-like tendon right in the front of the elbow joint in the cubital fossa. And the source emphasizes its importance as a guide. The brachial artery lies immediately on its medial side at the elbow. That relationship is key.
Which leads us directly to palpating the brachial artery itself.
Correct. You can feel the pulse of the brachial artery right there in front of the elbow joint, just medial towards the inside relative to that biceps tendon. This is the standard location where healthcare professionals place a stethoscope to listen to blood flow when measuring blood pressure. That's the spot.
Okay. The ulnar nerve is also on the list of palpables. The funny bone nerve.
Ah, yes, the famous funny bone. You can literally roll this nerve with your finger right behind the medial epicondyle. It feels like a cord slipping under your finger. That jolt you get when you hit your elbow there, that's the sensation traveling along this nerve.
And the source had a very specific clinical note about this.
It did. It mentioned that the ulnar nerve can become noticeably thick and enlarged in cases of leprosy. Palpating it there behind the medial epicondyle is part of the clinical examination in suspected cases, a key diagnostic sign. Very specific, but important.
Wow. Okay. Finally, the superficial cubital veins.
These are the veins you can often see right under the skin on the front of your elbow, especially if you're fair-skinned or well-hydrated. To make them more prominent, you apply pressure higher up on the arm, like using a tourniquet or just squeezing firmly and clench your fist. That makes them pop out.
And the source names a few specific ones.
Yes. The cephalic vein runs upwards along the lateral border of the biceps. The basilic vein runs upwards along the medial border of the lower half of the biceps.
And connecting them.
The median cubital vein, this is a really important vein. It runs obliquely across the front of the elbow, usually upwards and medially, connecting the cephalic and basilic veins. As the source hints, and as many people know from experience.
Getting blood drawn.
Exactly. This vein has significant clinical importance, particularly for drawing blood and IV access. It's often the easiest and safest one to use.
Okay, so those landmarks give us our external reference points, our way of orienting on the physical body based on this anatomical map. Really useful starting point. Now that we've looked at the basic framework and surface features, let's dive back into those internal divisions, the compartments. You mentioned the septa dividing them.
Right. Re-emphasizing, the arm is divided into anterior and posterior compartments by the medial and lateral intermuscular septa.
And these septa, they're extensions of the deep fascia, attached to the borders and supracondylar ridges of the humerus, and they get more defined lower down in the arm. But they aren't solid walls everywhere, are they? Things pass through.
No, and this is a crucial detail from the source, really key for understanding the pathways. Certain structures have to pass through these septa to get from one compartment to the other, or just to follow their designated path down the limb. The medial intermuscular septum, for example.
The one on the inside.
Yes, that one is pierced by the ulnar nerve and the superior ulnar collateral artery. They punch right through it.
So the ulnar nerve uses that septum like a doorway to move from the anterior to the posterior side of the arm to get behind the elbow.
Exactly. It ducks behind the scenes there. And the lateral intermuscular septum, the one on the outside, is pierced by the radial nerve.
Okay.
It's also pierced by the radial collateral artery, which the source notes is also known as the anterior descending branch of the profunda brachii artery. We'll come back to that artery.
So the radial nerve uses the lateral septum to move from the posterior compartment, where it runs in that spiral groove, forward into the anterior compartment in the lower part of the arm. These piercing points are vital anatomical transitions.
Absolutely critical junctions. And the source also highlights that within the anterior compartment itself, there are actually additional septa, creating even more organization. It's not just one big space in front.
Right, I saw that. A transverse septum and an anteroposterior septum. What do those do?
Okay, the transverse septum is basically a fibrous layer separating the biceps muscle, which is more superficial, from the deeper brachialis muscle. An interesting detail here, and the source points this out, is that the musculocutaneous nerve, which supplies these muscles, actually runs within or is enclosed by this septum for part of its course.
Like it's using the septum as its own specific tunnel or pathway?
Precisely, like it has its own dedicated channel between those two muscles. Then there's the anterior-posterior septum. This separates the brachialis muscle medially from the muscles that originate from the lateral supracondylar ridge laterally, like brachioradialis.
And structures run in that one too.
Yes, so this septum encloses the radial nerve and the anterior descending branch of the profunda brachii artery as they pass through the lower part of the anterior compartment on the lateral side. So even within the main compartments, there are these more granular structures guiding nerves and vessels. It's quite intricate.
It really is. Let's focus now on the anterior or flexor compartment. What are the main muscles that power movement here, the big players?
Okay, the primary muscles are the coracobrachialis, the biceps brachii, and the brachialis. Three main ones. Let's start with the coracobrachialis. It's maybe the least well-known of the three.
The source describes its origin from the tip of the coracoid process of the scapula.
Yes, specifically the medial aspect of the tip of the coracoid process, right alongside the origin of the short head of the biceps. They start together there. It then inserts onto the middle 5 centimeters or so of the medial border of the humerus shaft.
Okay, so upper arm, medial side, nerve supply.
Its nerve supply, crucially, is from the musculocutaneous nerve. With root values C5 to C7, that nerve actually pierces it, remember?
Right, pierces it, and its action. What does coracobrachialis do?
Its primary action is flexing the arm at the shoulder joint, bringing the arm forward. It also assists a bit in adduction, pulling the arm towards the body.
Now, the source gives this muscle a special designation, morphological importance. This feels like a key insight the source wants us to grasp, something beyond just origin and insertion.
It really is. It highlights a comparative anatomy perspective, looking at evolutionary relationships. Morphologically, the coracobrachialis in the arm is considered equivalent to the muscles of the medial compartment of the thigh in the lower limb, though obviously the thigh's medial compartment is much larger and more complex.
Like adductors in the thigh.
Kind of analogous, yes. The source also mentions it's evolutionarily considered a three-headed muscle, tricipital, in some animals. In humans, the upper two heads apparently fused, and the lowest head typically disappears during development.
But sometimes that lowest head doesn't disappear. It can persist.
Correct. And the persistence of this lowest head is linked to the potential formation of something called the ligament of Struthers. This isn't present in everyone, it's an anatomical variation.
Okay, what is this ligament?
When it is present, it's a fibrous band that might extend from a little bony projection on the humerus called the trochlear spine, or sometimes just a spur of bone, down to the medial epicondyle. If present, this third head of the coraca brachialis might insert into this ligament.
And why would this ligament be clinically significant if someone has it?
Because, as the source notes, the median nerve and sometimes the brachial artery, or even both, can pass underneath this ligament. If the ligament is particularly thick or tight, or if there's some swelling or injury, it can compress these vital structures.
Leading to problems down the arm.
Exactly. It could cause symptoms like pain, numbness, tingling, or weakness in the forearm and hand, mimicking carpal tunnel sometimes, but the compression is much higher up. It's a classic example of how anatomical variation can have real-world clinical consequences. You need to know it might be there.
That's a powerful takeaway. Seemingly minor variations matter a lot clinically. The source also makes a broader point connecting the arm to the lower limb based on embryology, right? Something about rotation.
Yes, it links the anterior compartment of the arm to the flexor and medial compartments of the thigh. This homology, the similarity, is explained by the 90-degree medial rotation that occurs in the developing lower limb bud during embryological development.
So the leg rotates inwards as it develops.
Essentially, yes. This rotation causes the initially anterior, which would be extensor, compartment of the lower limb to end up posteriorly. And the initially posterior flexor adductor compartment ends up anteriorly and medially. This makes the final arrangement in the leg mirror, in a way, the flexor-extensor arrangement we see in the arm. It's a developmental explanation for the layout.
Fascinating stuff.
Yeah.
All right, moving on to the muscle that defines the anterior arm for most people. The biceps brachii.
The biceps, famous for its shape, and as the name implies, it has two heads of origin. The short head arises from the lateral aspect of the tip of the coracoid process, right next to the coracobrachialis origin we just talked about.
Okay, short head from the coracoid process. And the long head, where does that come from?
The long head is quite unique in its origin. It originates from the supraglenoid tubercle of the scapula. That's a small bump of bone just above the shoulder joint socket, the glenoid cavity. It also arises partly from the glenoidal labrum, which is that fibrocartilaginous ring that deepens the socket.
And the source made a key point about this long head tendon.
Yes, it's intracapsular. The tendon of the long head actually passes through the shoulder joint capsule itself, arching over the head of the humerus, although it remains outside the synovial membrane that lines the joint cavity proper. So it's inside the fibrous capsule, but outside the synovial lining. A very specific relationship.
That's a detail you might miss without the source clarifying it. And there was a mnemonic for the origins.
Yes, the memorable, if slightly quirky mnemonic the source provides. You walk shorter to a street corner, you ride longer on a superhighway.
Okay, let's break that down.
Shorter head goes to the coracoid process, the street corner. Longer head goes to the supraglenoid tubercle, the superhighway. Simple, maybe a bit silly, but effective for recall.
I like it. Where does this powerful muscle insert? Where does it attach down at the elbow?
It inserts via a strong tendon onto the posterior rough part of the radial tuberosity, and it's a bump on the radius bone just below the elbow. A specific anatomical detail the source highlights is that as the tendon approaches this insertion, it twists on itself.
It twists?
The fibers that were initially on the front side of the tendon become lateral, and those that were on the back become medial. This twist is thought to be related to its powerful supinating action, helping it kind of wrap around the radius as it pulls.
Interesting. And there's a bursa there.
Yes, a bicipital radial bursa, a small fluid-filled sac, separates the tendon from the smoother anterior part of the radial tuberosity, reducing friction during pronation and supination movements.
And there's that fibrous extension, the bicipital aponeurosis. It comes off the tendon.
Exactly, a flattened band of fascia that extends obliquely from the biceps tendon across the cubital fossa towards the ulna on the medial side. Clinically, this aponeurosis is highly important.
Why is that?
It forms part of the roof of the cubital fossa and provides a protective layer separating the superficial median cubital vein, the one often used for IVs and blood draws,
Yeah.
from the deeper, more vulnerable brachial artery and median nerve. It's like a protective shield.
Good to know. The nerve supply for the biceps.
Straightforward. The musculocutaneous nerve with C5 and C6 root values primarily.
And its actions. It's famous for flexing the elbow, obviously, but the source highlights another major role, maybe even more important.
Absolutely. While it's a strong flexor of the elbow, the source explicitly states its most powerful action is as a supinator of the forearm, turning the palm upwards or forwards.
Turning the palm up. Supination.
Right. And this supinating strength is especially pronounced when the elbow is flexed. Think about using a screwdriver. That twisting motion powerfully engages the biceps because you're supinating against resistance with your elbow bent. That's prime biceps work.
An excellent point. So it's not just about making a muscle for show.
No, its supination role is functionally critical for many daily tasks requiring strength, like turning keys, opening jars, things like that. The short head also helps flex the arm at the shoulder, and the long head because it passes through the shoulder joint.
The intracapsular part.
Yes, that helps stabilize the head of the humerus and the glenoid socket, particularly preventing it from being pulled upwards during activities like lifting heavy objects.
How is the biceps tested clinically? How do you check its function?
You test its strength simply by asking the patient to flex their elbow against your resistance. You can feel the muscle bulge and harden. The source also mentions the biceps reflex.
The reflex hammer test.
Exactly. This is tested by placing your thumb over the biceps tendon in the cubital fossa and tapping your thumb with the reflex hammer. The patient's forearm should be relaxed, slightly pronated, palm down, and partially extended. A normal reflex is a quick, visible, or palpable jerk-like flexion of the elbow. This confirms the integrity of the musculocutaneous nerve and the C5-C6 spinal cord segments.
Okay. Our third muscle in the anterior compartment is the brachialis. Where does that fit in?
The brachialis muscle lies deep to the biceps, kind of like a foundation underneath it. It originates from a large area on the lower half of the front of the humerus, covering both the anteromedial and anterolateral surfaces, and also the anterior border. It also takes some origin from the medial and lateral intermuscular septa down low.
A broad origin on the humerus.
Very broad. Superiorly, its origin actually wraps around and sort of embraces the lower insertion point of the deltoid muscle laterally.
And its insertion. Where does it attach?
It inserts onto the coronoid process and the ulnar tuberosity, two features on the ulna bone near the elbow joint. Specifically, it attaches to the rough anterior surface of the coronoid process of the ulna.
Nerve supply for the brachialis.
Yeah.
Anything unusual here?
Its main motor supply is, again, the musculocutaneous nerve. However, the source includes another interesting detail. It also receives proprioceptive fibers, sensory fibers about position sense from the radial nerve.
Proprioception. That's the body's sense of where its parts are.
Exactly, position and movement sense. So the musculocutaneous nerve makes the brachialis contract motor, but the radial nerve fibers help the brain understand the state of contraction and the position of the brachialis muscle, and thus the elbow joint. It's a dual innervation, but for different function.
Okay, interesting distinction. And its action. What does brachialis primarily do?
Simple and direct. It's a pure flexor of the forearm at the elbow joint. It's considered the workhorse flexor of the elbow. Unlike the biceps, it doesn't contribute significantly to supination or pronation, nor does it act on the shoulder joint. It just bends the elbow reliably and powerfully. Okay, now let's map the nerves that traverse or supply this anterior compartment. We've mentioned it a lot already, but the musculocutaneous nerve is the main one.
Yes, the source calls it the main nerve of this compartment. Root value C5, C7. It starts its journey branching off the lateral cord of the brachial plexus in the lower part of the axilla, right next to the third part of the axillary artery.
And its distinctive course, what's its signature move?
It travels downwards and laterally, but its most characteristic feature, the thing to remember, is that it pierces the coracobrachialis muscle to enter the anterior compartment proper. That piercing is a key anatomical landmark for identifying it.
A very specific point to look for during dissection for sure. After piercing the coracobrachialis, where does it go?
It runs downwards and laterally, sandwiched between the biceps brachii muscle more superficially and the brachialis muscle deeper down within that transverse septum we mentioned. It continues in this plane until it reaches the lateral side of the biceps tendon, just above the elbow.
And its termination, what happens to it down there?
About 2 centimeters or so above the bend of the elbow, it emerges from under the biceps, passes through the deep fascia to become superficial, and then continues down the forearm as the lateral cutaneous nerve of the forearm, It effectively changes its name and primary function from motor to the arm muscles to sensory for the forearm skin.
The source lists its relations in the lower axilla before it dives into the arm.
Yes, a detailed list, important for understanding brachial plexus anatomy. Anteriorly, it's covered by pectoralis major. Posteriorly, it lies in front of the subscapularis muscle. Medially, it's close to the axillary artery and the lateral root of the median nerve. Laterally, it's associated with the coracobrachialis muscle, which it then pierces, and in the arm proper. As noted, its key relations are running between the biceps and brachialis muscles.
Let's break down its branches and distribution. What does it actually do?
Okay, muscular branches go to all three muscles of the anterior compartment. Coracobrachialis, which it pierces, both heads of biceps brachii, and the brachialis muscle. It's the motor nerve for elbow flexion.
Cutaneous branches, the sensory part.
That's its terminal branch, the lateral cutaneous nerve of the forearm. This nerve provides sensation to the skin on the entire lateral side of the forearm, from the elbow all the way down to the wrist. And interestingly, the source notes it also supplies the skin over the fleshy prominence at the base of the thumb, the thenar eminence, or ball of the thumb.
Oh, okay, so lateral forearm and thumb base. Articular branches, does it supply joints?
Yes, it sends branches to the elbow joint, primarily arising from the nerve fibers that supply the brachialis muscle, which lies right over the joint. It also gives a branch to the shoulder joint, which apparently enters the humerus bone, along with the nutrient artery to the humerus.
Interesting path for a joint branch. And it communicates with other nerves. Does it talk to its neighbors?
Yes, its terminal branch, the lateral cutaneous nerve of the forearm, has communicating branches that connect with several other cutaneous nerves in the area. The source lists connections with the superficial branch of the radial nerve, the posterior cutaneous nerve of the forearm, also from the radial, and the palmar cutaneous branch of the median nerve. It's part of a network ensuring broad sensory coverage and maybe some overlap.
Good integration. Now, the median nerve is another major nerve found in the arm, though it mostly just passes through this section rather than supplying muscles here.
Right, and the source highlights its very close relationship with the brachial artery. Their relative position changes as they go down the arm, and that's a key anatomical relationship to track.
Absolutely. In the upper part of the arm, the median nerve typically lies lateral to the brachial artery, to the outside.
Then, around the middle of the arm, what happens?
It crosses the brachial artery. It usually passes anteriorly in front of the artery, moving from the lateral side to the medial side. This crossing point is often near the level where the coracobrachialis muscle inserts onto the humerus, that level again.
The transitional zone. And after crossing,
it continues down on the medial side of the brachial artery all the way to the elbow, where it enters the cubital fossa as the most medial of the major structures we find there. Remember MBBR.
what branches does the median nerve give off in the arm itself above the elbow?
The source lists relatively few here, as its main branching party happens down in the forearm. In the arm proper, it might give off a branch to the pronator teres muscle, one of the forearm muscles, but this typically arises just above the elbow joint, maybe even in the cubital fossa itself. It also gives small vascular branches to the brachial artery wall and an articular branch to the elbow joint, usually arising near the joint. So not much action in the arm itself. The source also briefly reminds us how the median nerve is formed way back up in the axilla.
Yes, it's formed by the coming together of two roots from the brachial plexus. A lateral root from the lateral cord and a medial root from the medial cord. These roots typically embrace the third part of the axillary artery, often forming a characteristic M shape with the musculocutaneous nerve laterally and the ulnar nerve medially. The medial root usually crosses in front of the artery to join the lateral root.
Okay. The ulnar nerve is also a traveler through the arm. Where is it initially?
In the upper part of the arm, the ulnar nerve runs alongside the brachial artery, but on its medial side. So brachial artery in the middle, median nerve lateral, ulnar nerve medial high up.
But it doesn't stay in the anterior compartment for its whole journey down the arm, does it?
No, this is another key transition point we noted earlier with the septa. At about the level of the insertion of the coracobrachialis, that mid-arm level again, the ulnar nerve leaves the anterior compartment. It does this by piercing the medial intermuscular septum.
And where does it go after piercing that medial septum?
It enters the posterior compartment of the arm. It's accompanied by the superior ulnar collateral vessels, which also pass through the septum at roughly the same point. It then continues down on the posterior aspect of the medial side of the arm, eventually passing behind the medial epicondyle of the humerus, heading towards that funny bone groove.
Right, it ducks out of the front. Finally, the radial nerve also has a presence and important relations in the arm, even though much of its work is posterior or further down.
Yes. In the upper arm, where the brachial artery begins, the radial nerve lies posterior to the artery, behind it. But like the ulnar nerve, it quickly changes its position relative to the anterior compartment.
It doesn't stay behind the artery for long.
No, it leaves the area behind the brachial artery quite high up by angling posteriorly and laterally to enter the radial groove, also called the spiral groove, on the back of the humerus. This is where it travels through the posterior compartment, accompanied by the deep artery of the arm, the profundo brachii artery.
But the source mentions it reappears on the front lower down.
Yes. After traversing the spiral groove on the posterior side, in the lower part of the arm, the radial nerve pierces the lateral intermuscular septum to return to the anterior compartment, specifically on its lateral aspect.
Okay, so it comes back around to the front, but on the outside.
Exactly. Here, in the lower lateral anterior arm, it lies in the groove between the brachialis muscle on its medial side and the brachioradialis and extensor carpi radialis longus muscles, which originate from the lateral supracondylar ridge on its lateral side. The source notes its muscular branches are primarily discussed with the posterior arm, but its position here and its proprioceptive supply to brachialis are relevant to the anterior region before it gets to the cubital fossa.
Okay, let's map the main artery of the arm, the brachial artery. This is a big one.
Absolutely. The brachial artery is the direct continuation of the axillary artery. It officially begins at the lower border of the teres major muscle. That's one of the muscles of the posterior shoulder upper back area, forming the posterior axillary fold.
And its path down the arm. It runs downwards and slightly laterally along the front of the arm. It's remarkably superficial throughout most of its course, which, as we discussed with landmarks, is why you can palpate its pulse so easily and use it for blood pressure measurement. It's not buried deep.
What's its full extent? Where does it end?
It runs from that lower border of the teres major all the way down to the front of the elbow joint, specifically terminating at about the level of the neck of the radius bone within the cubital fossa.
And how does it terminate? What does it turn into?
Right there in the cubital fossa, at the level of the neck of the radius, it divides into its two terminal branches. The radial artery, which heads down the lateral forearm, and the ulnar artery, which heads down the medial forearm. This division point is typically just medial to the biceps brachii tendon. Let's detail its relations, as the source does comprehensively. This is really key for understanding clinical procedures and potential injury patterns.
Okay. Superficial throughout, as noted, covered only by skin, fascia, and maybe overlapped slightly by muscles medially or laterally. And it's accompanied by two vena comitants, that's the term for paired veins, that typically travel alongside a medium-sized artery, often wrapped around it.
What's anterior to it in front?
In the middle of the arm, it's crossed anteriorly by the median nerve, as the nerve moves from its lateral side to its medial side. Then down in front of the elbow, in the cubital fossa, it's covered anteriorly by the bicipital aponeurosis and often the median cubital vein in the superficial fascia.
Okay. Posteriorly, what's behind the brachial artery?
In the upper part, it lies on the long head of the triceps brachii muscle. A bit lower, the radial nerve and the profunda brachii artery are posterior to it, just before they dive back into the spiral grooves. Even lower down, it rests directly on the insertion of the coracobrachialis and then on the brachialis muscle.
Medially, what's on its inner side?
In the upper part of the arm, it's related medially to the ulnar nerve and the basilic vein before the vein pierces the deep fascia. In the lower part of the arm, the median nerve becomes medial to it after crossing over.
And laterally, on its outer side.
In the upper part of the arm, it's related laterally to the coracobrachialis muscle and the biceps brachii muscle, and also the median nerve before the nerve crosses. Right down at the elbow, the prominent biceps brachii tendon lies immediately lateral to it.
And the source gives us that vital summary, that mnemonic, for the structures right in the cubital fossa, from medial to lateral. Let's hear it again.
The MBBR mnemonic. It's worth repeating. Median nerve, brachial artery, biceps brachii tendon, radial nerve, though the radial nerve is on a slightly deeper plane laterally. Knowing that order in the cubital fossa is absolutely critical for clinical practice, for avoiding structures during procedures.
Couldn't agree more. What about the branches of the brachial artery as it comes down the arm?
It gives off several important branches before it terminates. There are numerous unnamed muscular branches that supply the surrounding muscles, like biceps and brachialis. Then there are named branches. The profunda brachii artery is a large branch, usually the largest, arising high up, just below the teres major. It follows the radial nerve into the spiral groove, the deep artery of the arm.
Okay, profunda brachii goes posterior. What else?
The superior ulnar collateral branch arises in the upper or middle part of the arm and accompanies the ulnar nerve as it passes posteriorly through the medial intermuscular septum. There's also usually a nutrient artery that arises from the brachial to supply the humerus bone itself, entering the bone around midshaft.
And lower down near the elbow.
The inferior ulnar collateral artery, sometimes called the supratrochlear branch, arises in the lower part of the arm above the elbow. This is a significant contributor to the arterial network, the anastomoses, around the elbow joint. And then, of course, its terminal branches are the radial and ulnar arteries, formed by its bifurcation in the cubital fossa. Okay, let's circle back to some key clinical points related to the anterior compartment that the source highlighted. Practical applications.
Yeah, let's reinforce those. Reinforcing what we discussed under surface landmarks. The brachial artery's pulse is felt, and more importantly for blood pressure, auscultated, listen to, just medial to the biceps tendon at the elbow. This is the universal standard location for taking blood pressure for good reason. The artery is reliably superficial and relatively fixed here.
Makes sense. And controlling bleeding in the arm.
The brachial artery can be compressed against the humerus to stop or slow bleeding further down the limb, say from a forearm or hand injury. The source identifies the most favorable spot for manual compression as the middle of the arm, where the artery lies on the tendon of the coracobrachialis muscle, or just medial to the humerus. The firm structures underneath provide a surface to compress the artery effectively.
Blood collection. Usually veins, but sometimes arterial.
Exactly. While venous blood is the standard for most tests, blood for arterial blood gas analysis, checking oxygen and CO2 levels, is sometimes needed, and it can be drawn directly from the brachial artery, often in the cubital fossa where it's accessible. Requires skill, obviously.
And nerve testing relevant to this compartment.
The biceps reflex test, which we covered when discussing the biceps muscle, specifically assesses the function of the musculocutaneous nerve and the integrity of the C5 and C6 spinal cord segments. A tap on the tendon should cause a twitch or flexion.
The source dedicates a specific section to summarizing the changes at the level of insertion of coracobrachialis. This sounds like a particularly important anatomical cross-section or landmark level.
It truly is a crucial transitional zone where many significant structures change their position, relationships, or character. It's worth pulling those threads together. Let's integrate these changes as we've discussed the individual structures. For the bone itself, around this level, the shaft of the humerus changes from being more or less circular in cross-section higher up to becoming more triangular in cross-section lower down.
Okay, the bone shape changes. And the fascial septa, those internal walls.
The medial and lateral intermuscular septa, those internal fibrous walls, become much more distinct and well-defined from this level downwards. They attach more firmly to the supracondylar ridges, really reinforcing the separation of the anterior and posterior compartments below this point.
Muscle changes around this level.
This level marks the lower insertions of two muscles coming from above, the deltoid muscle laterally and the coracobrachialis muscle medially. Just inferior to this, it's where the upper origins of the brachialis muscle anteriorly and the medial head of the triceps brachii posteriorly begin their attachments to the humerus. So muscle attachments are shifting significantly here.
Arterial changes. What's happening with the blood vessels?
This is where the brachial artery, which might be slightly posterior or medial in the upper arm, comes to lie more directly on the anterior aspect of the brachialis muscle. The profunda brachii artery, running posteriorly with the radial nerve, typically divides into its anterior and posterior descending collateral branches around here, preparing to contribute to the elbow anastomoses. The superior ulnar collateral artery branches off the brachial near here, and importantly, pierces the medial intermuscular septum along with the ulnar nerve. Also, the main nutrient artery to the humerus often enters the bone around this level, usually arising from the brachial artery. Lots happening with arteries, venous changes. The basilic vein, which runs superficially up the medial side of the arm, often pierces the deep fascia around this level to dive deeper and join the venae comitatantes of the brachial artery, contributing to the formation of the main, deeper brachial veins. The paired venae comitatantes themselves may start to unite into fewer, larger brachial veins around here too, and the major nerve changes. This seems like a hub for nerve shifting. Absolutely. The median nerve makes its significant crossing, typically anterior to the brachial artery, moving from the lateral to the medial side. The ulnar nerve makes its decisive exit from the anterior compartment by piercing the medial intermuscular septum to enter the posterior compartment. The radial nerve, after traversing the posterior spiral groove, pierces the lateral intermuscular septum to reappear on the lateral side of the anterior compartment lower down. Additionally, the source notes that the medial cutaneous nerve of the arm and the medial cutaneous nerve of the forearm often pierce the deep fascia around this level to become superficial and supply skin sensation.
Wow. So yes, that level, roughly mid-arm coinciding with the corcu-brachialis insertion, is a major hub of anatomical activity and a critical point for understanding the changing relationships of almost all the major structures passing through the arm. It's a key landmark level.
Let's focus in detail now on the cubital fossa, that vital transition zone at the front of the elbow we mentioned.
Right, the cubital fossa. It's that triangular hollow right at the front of the elbow. The source notes its functional and structural similarity, its homology, to the popliteal fossa, which is the diamond-shaped space behind the knee in the lower limb. Both are major transition areas for nerves and vessels between limb segments.
What defines its triangular shape? The boundaries.
It has muscular boundaries. The lateral boundary, the outside edge, is formed by the medial border of the brachiradialis muscle. The medial boundary, the inside edge, is formed by the lateral border of the pronator teres muscle.
Okay. Brachiradialis laterally, pronator teres medially. The base of the triangle, is that up or down? The base is directed upwards towards the arm. It's represented by an imaginary line drawn between the front of the medial and lateral epicondyles of the humerus.
And the apex, the point of the triangle.
The apex points downwards, towards the forearm. It's formed by the area where the brachiradialis muscle crosses over the pronator teres muscle, where those two boundary muscles meet.
Okay, got the shape. Let's build up the layers of its roof from outside in.
Starting superficially, you have the skin, obviously. Beneath that, the superficial fascia. This layer is important because it contains those superficial veins we talked about, the median cubital vein, the cephalic vein laterally, the basilic vein medially. It also contains cutaneous nerves. The lateral cutaneous nerve of the forearm, from musculocutaneous, travels with the cephalic vein here, and the medial cutaneous nerve of the forearm travels with the basilic vein.
So veins and sensory nerves in the superficial layer, and deeper in the roof.
Below the superficial fascia is the deep fascia of the arm and forearm, which is continuous across the fossa. And then, forming a significant reinforcing layer of the roof, is that strong fiber sheet we've discussed, the bicipital aponeurosis, extending medially from the biceps tendon. This forms a strong protective layer over the deeper artery and nerve.
Okay, what forms the floor of this hollow? What's at the bottom?
The floor is muscular. It's formed by two muscles primarily. The brachialis muscle superiorly, its insertion onto the ulna is deep here, and the supinator muscle inferiorly, which wraps around the upper part of the radius.
Now, the critical contents within the cubital fossa. The source lists them clearly, following our MBBR mnemonic from medial to lateral. Let's go through them.
Absolutely. Starting from the medial side, thumb side if palm is up. M is for median nerve.
This is the most medial major structure deep within the fossa.
Yes. And it's not just passing through passively here. Within the cubital fossa, the median nerve gives off several muscular branches to some of the superficial forearm flexor muscles. Specifically, branches to flexor carpi radialis, palmaris longus, and flexor digitorum superficialis often arise here. After passing through the fossa, it leaves the area by passing between the two heads of the pronator teres muscle to enter the forearm proper.
Okay, median nerve first. Next, B for brachial artery.
The brachial artery is the central vessel in the fossa, lying just lateral to the median nerve. And remember, this is its termination point right here. Typically at the level of the radial neck, it divides into its two terminal branches, the radial artery and the ulnar artery. The source notes the radial artery is generally smaller and lies more superficially than the ulnar artery right at the bifurcation.
Any important branches coming off these terminal arteries within the fossa itself?
Yes, they start branching quickly. The radial artery gives off the radial-recurrent branch almost immediately, which turns back upwards to participate in the elbow anastomoses we'll discuss later. The ulnar artery takes a deeper pass here, passing deep to both heads of the pronator teres muscle. It runs downwards and medially, separated from the median nerve by the deep head of pronator teres. Within the fossa, the ulnar artery gives off the anterior ulnar recurrent and posterior ulnar recurrent branches, also heading back up towards the elbow anastomoses, and importantly, the common interosseous artery.
And the common interosseous artery divides quickly, too.
Very quickly. It's a very short trunk that dives posteriorly and divides into the anterior interosseous artery, which runs down the front of the interosseous membrane between radius and ulna, and the posterior interosseous artery, which goes to the back of the forearm. The posterior interosseous artery, in turn, gives off the interosseous recurrent branch, another key contributor to the elbow's collateral circulation network. So lots of branching happening right at the elbow.
Okay, so median nerve, brachial artery, and its division. Third content in the MBBR mnemonic, another B.
The tendon of the biceps brachii muscle. This is the prominent cord-like structure we felt earlier as a key surface landmark. In the cubital fossa, it lies lateral to the brachial artery and medial to the radial nerve.
Got it. And finally, R4.
Radial nerve. The radial nerve and its terminal branches are the most lateral of the major contents listed. The source is careful to mention. It lies on a deeper plane compared to the median nerve and brachial artery here. It descends into the fossa, having passed anterior to the lateral epicondyle.
And its fate in the fossa. What happens to the radial nerve here?
It typically terminates within the fossa, or just proximal to it, by dividing into its two main terminal branches, the superficial branch and the deep branch. The deep branch is also known as the posterior interosseous nerve and is primarily motor. It quickly gives branches to the extensor carpi radialis brevis muscle and the supinator muscle, which forms part of the fossa's floor. It then leaves the fossa by piercing through the supinator muscle to get to the posterior forearm.
And the superficial branch.
The superficial branch of the radial nerve is primarily sensory. It continues downwards in the anterior forearm, running under the brachioradialis muscle for some distance, before eventually becoming superficial further down to supply sensation to the back of the hand.
This cubital fossa is clearly a high-traffic area with significant clinical implications. You don't want to mess around in there without knowing the layout.
Absolutely not. The source lists several key clinical reasons why understanding its anatomy is essential, beyond just academic knowledge. Foremost, that median cubital vein running in the roof, superficial fascia, is the most common site for venipuncture drawing blood and for administering intravenous fluids or medications. Its accessibility and size make it ideal. It's also often the access point used for introducing cardiac catheters that need to be threaded up towards the heart.
Blood pressure measurement again. Comes up a lot.
Yes, it's reiterated here because this is the spot. The brachial artery in the cubital fossa, just medial to the biceps tendon, is the universal site for auscultation when measuring blood pressure with a stethoscope and cuff.
And trauma implications. Fractures around the elbow.
Hugely important here. Understanding the precise arrangement of nerves and vessels in the cubital fossa is vital when dealing with fractures around the elbow, particularly supracondylar fractures of the humerus, which are common in children. These injuries put the brachial artery and the median nerve, which are medial, and the radial nerve, laterally, at significant risk of being stretched, bruised, or even torn by displaced bone fragments.
And that bicipital aponeurosis plays a role here, too.
Yes, its protective role is clinically relevant. By separating the superficial veins from the deeper brachial artery and median nerve, it provides a small measure of protection during superficial procedures like blood draws. But in deep trauma, obviously, everything is vulnerable. Knowing that layer is there is important context.
Okay, let's shift our focus now to the posterior compartment of the arm, the extensor side. Things seem a bit simpler back here.
Anatomically, yes, it's somewhat simpler in terms of the number of muscles. It's dominated by one single large muscle, the triceps brachii, but it also contains the radial nerve and the profunda brachii artery, which travel through it for a significant portion of their course. And, as we noted, the ulnar nerve passes through the lower part of the posterior compartment on the medial side after it pierces the septum.
The triceps brachii named for its three heads of origin, right?
That's right. Triceps, three heads. The long head originates from the infraglenoid tubercle of the scapula that's a bony bump just below the shoulder joint socket, glenoid cavity. The source notes this is the longest of the three heads, hence the name, and it's the only head that crosses the shoulder joint.
Okay, long head from the scapula, the lateral head.
The lateral head arises from an oblique ridge on the upper part of the posterior surface of the humerus, specifically superior to the radial or spiral groove. It corresponds roughly to the lateral lip of this groove.
And the medial head, where does that come from?
The medial head has a very broad origin. It arises from a large triangular area on the posterior surface of the humerus below the radial groove. So the groove separates the origins of the lateral and medial heads. The medial head also takes some origin from both the medial and lateral intermuscular septa. It's deep to the other two heads in the upper part.
Where do these three heads converge? How do they insert?
The long and lateral heads contribute fibers to form a broad, flat, superficial tendon. This tendon covers the deeper medial head and inserts primarily into the posterior part of the superior surface of the olecranon process. That's the prominent bony tip of your elbow, part of the ulna bone. The medial head inserts partly into this superficial tendon and partly directly onto the olecranon itself, deep to the main tendon.
The source mentions some fibers inserting into the joint capsule, a small muscle.
Yes, a few deeper fibers, usually from the medial head, insert directly into the capsule of the elbow joint posteriorly. These fibers are sometimes considered a small separate muscle called the articularis cubitii or subunconeus. Their purpose is thought to be functional. During active extension of the elbow, they pull the posterior joint capsule upwards, preventing it from getting pinched or trapped between the olecranon and the humerus.
Clever. Nerve supply for the triceps. Who powers this big extensor?
It's all supplied by the radial nerve, with primary root values from C7 and C8. A key detail from the source is that each of the three heads typically receives a separate branch from the radial nerve. And importantly, these branches arise fairly high up. The nerves to the long and medial heads often arise way up in the axilla or the very upper part of the arm before the main trunk of the radial nerve even enters the spiral groove.
And this has a clinical implication for injuries.
Yes, a significant one. Because the nerves to the long and medial heads arise so high, proximally, in radial nerve injuries occurring in the arm, like within the spiral groove itself, a common injury site, the triceps often escapes complete paralysis. The long and medial heads might retain some or all of their function because their nerve supply originated proximal to the injury site. The lateral head, whose nerve branch often comes off within the groove, might be more affected. So you might lose some power, but not necessarily all elbow extension.
That's a crucial diagnostic point. What are the triceps' actions, primarily extension?
Yes, it's the primary, and crucially, the source emphasizes it's the only powerful active extensor of the forearm at the elbow joint. While gravity can extend the elbow passively if you just relax your biceps, the triceps provides the force for pushing movements, straightening the arm against resistance, like doing push-ups or throwing something.
And the long head does more.
Because the long head crosses the shoulder joint, originating from the scapula, it also assists in extending the arm at the shoulder, pulling the arm backwards, and adducting the arm, pulling it towards the body. It also helps stabilize the head of the humerus in the glenoid cavity, particularly when the arm is abducted, raised out to the side.
How is triceps function tested clinically?
Pretty straightforward. You test tricep strength by having the patient hold their forearm partially flexed, like halfway bent, and asking them to extend their elbow forcefully against your resistance applied to their forearm. You can feel the muscle contract strongly on the back of their arm.
And the source mentioned something about which heads work when.
Yes, it noted that electromyography, EMG, studies, which measure muscle electrical activity, show that the medial head is pretty much active during all forms of elbow extension, even gentle, low-force ones. It's the workhorse. The long and lateral heads, however, seem to be recruited more significantly during powerful extension, especially when acting against resistance. They provide the extra boost when needed.
Interesting division of labor. Let's track the radial nerve again, focusing specifically on its course through this posterior compartment.
Okay, the radial nerve. As the source reminds us, it's the largest branch of the posterior cord of the brachial plexus, originating from root values C5 all the way through T1. It arises in the lower part of the axilla, posterior to the axillary artery.
How does it get from the axilla to the posterior arm?
Initially in the axilla, it runs behind the third part of the axillary artery. Then in the very upper arm, it briefly lies behind the brachial artery. Then it leaves the brachial artery by angling posteriorly and laterally. It passes through a space called the lower triangular space. This is an anatomical interval defined by the teres major muscle inferiorly, the long head of the triceps medially, and the shaft of the humerus laterally. Passing through this space allows it to reach the posterior aspect of the humerus and enter the radial or spiral groove.
This spiral groove is its crucial pathway through the posterior compartment, right?
Yes, absolutely. In the spiral groove, it winds downwards and laterally around the posterior surface of the humerus, nestled between the lateral head, which originates of the groove, and the medial head, which originates below the groove of the triceps. It's in direct contact with the bone here, which is why it's vulnerable to fractures, and it's accompanied throughout the groove by the profunda brachii artery.
And after the groove, where does it go next?
After traversing the spiral groove, it reaches the lateral side of the arm, roughly 5 centimeters or so below the deltoid tuberosity insertion point. As we discussed earlier, this is where it pierces the lateral intermuscular septum to enter the anterior compartment on its lateral aspect. From there, it continues down towards the cubital fossa between brachialis and brachioradialis.
Let's detail the branches the radial nerve gives off specifically while it's in the axilla and traveling through that radial groove in the posterior compartment. What comes off it back there?
Okay. Before it even enters the spiral groove, so high up in the axilla or the very upper arm, it gives off those important muscular branches to the long head and the medial head at the triceps.
Right, the ones that often survive spiral groove injuries.
Exactly. Then, while it's within the spiral groove itself, it gives off further muscular branches to the lateral head and the remainder of the medial head of the triceps. It also gives off a branch to the small anconeus muscle, which is down near the elbow joint laterally.
Okay, so all triceps heads and enconeus get supplied along the way. What about cutaneous sensory branches from this posterior region?
Yes, it gives off several important sensory branches back here. High up, often in the axilla, it gives off the posterior cutaneous nerve of the arm, which supplies sensation to the skin on the back of the arm, running straight down. Then, while it's in or emerging from the radial groove, it gives off the lower lateral cutaneous nerve of the arm, supplying skin on the lower outer arm, and the posterior cutaneous nerve of the forearm, which runs down the middle of the back of the forearm, supplying skin sensation.
So sensation to the back of the arm, the outer lower arm, and the back of the forearm all originate from radial nerve branches given off along its course through the posterior compartment or just as it exits.
Correct. Those sensory territories are key for diagnosing the level of a radial nerve lesion.
The companion artery running with the radial nerve in the posterior compartment is the profunda brachii artery, the deep artery.
Exactly. Profunda meaning deep. This is typically a large artery, often the first major branch coming off the brachial artery, arising just below the teres major muscle high in the arm. It's the main arterial supply accompanying the radial nerve posteriorly.
Its course. Does it just follow the nerve?
Pretty much. It follows the radial nerve closely through that lower triangular space and then winds around the humerus within the radial or spiral groove, lying between the nerve and the bone.
And it terminates by dividing, like the brachial artery does later.
Yes, usually just before it passes through the lateral intermuscular septum along with the radial nerve, or sometimes just after. It divides into its two main terminal branches, the anterior descending branch and the posterior descending branch. These branches are absolutely essential participants in the arterial network, the anastomoses, around the elbow joint.
Let's list its specific branches, as described in the source.
Okay. The radial collateral artery, which the source also calls the anterior descending branch, is one of its terminal divisions, and essentially acts as the continuation of the profunda artery's course anteriorly. It accompanies the radial nerve as it pierces the lateral septum and descends in the anterior compartment to the front of the lateral epicondyle. Down there, it anastomoses or connects with the radial recurrent artery, which is a branch coming back up from the radial artery in the forearm.
Okay, that's the anterior one, the middle collateral artery.
This is the other major terminal branch, also known as the posterior descending artery. It's often the largest branch of the profunda. It doesn't follow the radial nerve anteriorly. Instead, it descends posteriorly, often within the substance of the medial head of the triceps muscle. It eventually anastomoses with the interosseous recurrent artery, a branch coming up from the posterior interosseous artery in the forearm, specifically behind the lateral epicondyle. The source also notes it usually gives off a small branch that accompanies the nerve to the anconeus muscle.
Any branches heading upwards from the profunda?
Yes, usually there's a deltoid or ascending branch. This ascends between the long and lateral heads of the triceps high up near the shoulder and anastomoses, with the descending branch of the posterior circumflex humeral artery, which supplies the shoulder region, contributing to the blood supply around the surgical neck of the humerus and the shoulder joint.
And a nutrient artery to the bone.
Yes, the source mentions that a nutrient artery to the humerus frequently arises from the profunda brachii and enters the posterior surface of the humerus, often within the radial groove itself, behind the deltoid tuberosity. It's important to remember, though, as the source notes, that the main nutrient artery supplying the shaft of the humerus typically comes directly from the brachial artery itself in the anterior compartment, not always from the profunda brachii. But the profunda often gives one, too.
All these branches, the collaterals from the brachial and profunda, the recurrence from the radial and ulnar, they create this complex network of vessels around the elbow. Let's detail these anastomoses around the elbow joint. Why are they important?
This network, this anastomosis, is functionally very important. It creates a collateral circulation route. Think of it like a series of bypasses or interconnecting roads. It links branches from the brachial artery system, including its profunda brachii branch, above the elbow, with recurrent branches coming back up from the radial and ulnar arteries below the elbow.
And the point of this bypass system?
It ensures a robust and continuous blood supply to the elbow joint itself, the surrounding muscles, and the bones, even if one of the main arteries, like the brachial artery, is temporarily compressed, like during deep elbow flexion, or even blocked or ligated surgically higher up. Blood can find an alternative route around the obstruction to reach the forearm and hand. It's critical for limb viability.
Okay, the source breaks down the specific connections at 4 key points around the medial and lateral epicondyles. This seems like the core detail.
Yes, knowing these specific connections is key to understanding the network. Let's list them as the source does. First, in front of the lateral epicondyle of the humerus, on the outer front side of the elbow, the anterior descending radial collateral branch of the profunda brachii artery anastomoses with the radial recurrent branch of the radial artery.
Okay, profunda branch meets radial branch in front laterally. Second, behind the lateral epicondyle.
Behind the lateral epicondyle, the posterior descending branch of the profunda brachii artery, also called the middle collateral, anastomoses, with the interosseous recurrent branch, which comes up from the posterior interosseous artery.
Profunda branch meets interosseous branch behind laterally.
Got it.
Third, in front of the medial epicondyle, inner front side.
In front of the medial epicondyle, the inferior ulnar collateral branch, which came off the brachial artery low down, anastomoses with the anterior ulnar recurrent branch, which comes up from the ulnar artery.
Brachial branch meets ulnar branch in front medially, and fourth, behind the medial epicondyle.
Behind the medial epicondyle, the superior ulnar collateral branch, which came off the brachial higher up and ran with the ulnar nerve, anastomoses with the posterior ulnar recurrent branch, also coming up from the ulnar artery.
Brachial branch meets ulnar branch behind medially. That covers all 4 quadrants around the joint.
Exactly. Knowing these specific connections explains how blood can still effectively reach the forearm and hand, even if the brachial artery were to be tied off, say, in the middle of the arm during surgery or after trauma. It's the body's built-in backup vascular system for the elbow region.
Okay, let's bring together some of the crucial clinical implications now, focusing specifically on nerve injuries, which the source gives particular prominence to, especially the radial nerve.
Yes, the radial nerve is notoriously vulnerable to injury, and the source highlights that this commonly occurs in the region of the radial or spiral groove on the back of the humerus. We keep coming back to this spot.
Why is it so often injured right there in the groove?
Primarily because it lies in such direct contact with the bone as it wraps around the humerus shaft. There's very little protective soft tissue padding it right there. So any significant pressure against that part of the arm, or more dramatically, a fracture involving the shaft of the humerus in that region, can easily compress, stretch, bruise, or even sever the nerve.
And the source listed some classic causes.
Yes. Illustrative examples. Saturday night palsy, which is the classic scenario where someone falls asleep, often intoxicated, with their arm hanging over the sharp back of a chair, compressing the nerve for hours. Or crutch paralysis, caused by improper use of axillary crutches, where the top of the crutch presses up into the axilla and upper arm, compressing the radial nerve and other brachial plexus elements against the humerus. And of course, direct trauma from fractures of the humerus shaft in that midshaft region is a very common cause.
And what are the clinical effects? What does a patient experience with a radial nerve injury at this level, in the spiral groove?
The most characteristic and easily recognizable effect is weakness and loss of the ability to extend the wrist joint. This is clinically known as wrist drop. The patient's hand hangs limply downwards at the wrist because the extensor muscles in the forearm, which lift the hand up, are paralyzed or severely weakened.
And the source explains why wrist drop is so functionally disabling, beyond just not being able to lift the hand.
Yes, this is a key functional point. Even though the primary problem seems to be at the wrist drop significantly impairs your ability to grip objects effectively. You need your wrist extensor muscles to contract synergistically to stabilize the wrist in a slightly extended position whenever you make a fist or grip something tightly. Without this wrist stabilization, the finger flexor muscles cannot generate optimal force, making a strong grip impossible.
Try making a tight fist with your wrist bent fully down, you feel weak.
Exactly. You need that stable, slightly extended wrist platform for effective hand function. Wrist drop takes that away.
Which specific muscles are typically affected by an injury in the spiral groove?
Essentially, all the muscles supplied by the radial nerve distal to the point of injury in the groove. This primarily includes the main forearm extensor muscles responsible for wrist and finger extension muscles like brachioradialis, which also flexes the elbow but is radial innervated, extensor carpi radialis longus and brevis, wrist extensors, extensor digitorum, finger extensor, extensor pollicis longus, thumb extensor, and others in the posterior compartment of the forearm.
And the triceps. Is elbow expansion affected?
As we noted earlier, the triceps brachii is usually only partially affected or sometimes not noticeably weakened at all by an injury solely within the spiral groove. This is because the nerve branches to the long and medial heads often arise proximal to the groove, higher up in the arm or axilla. So elbow extension strength is often largely preserved, which helps differentiate a spiral groove injury from a more proximal radial nerve injury, like in the axilla.
Makes sense. And sensory loss. Where would the patient feel numbness?
There is typically some sensory loss along the distribution of the cutaneous branches that arise distal to the injury point or within the affected segment. This often manifests as a patch of numbness or altered sensation over a narrow strip on the back of the forearm and variable sensory loss on the lateral side of the dorsum, back of the hand, often over the base of the thumb and index finger, the anatomical snuff box area. The exact pattern can vary. The source provides a neat clinico-anatomical problem that wraps this up nicely. A motorcycle accident causing injury to the middle of the back of the arm.
Based on our anatomical map, the structure most likely injured right there is the radial nerve, lying directly on the humerus in the spiral groove.
Precisely. The mechanism fits perfectly, and the expected effects would be paralysis or weakness of the muscles supplied below that point, primarily the forearm extensors, leading to
the classic clinical presentation of wrist drop.
Exactly. That problem ties together the specific location, mid-posterior arm, the vulnerable structure, radial nerve and spiral groove, the likely mechanism, trauma fracture, the affected muscles, forearm extensors, and the resulting clinical sign, wrist drop. It's a perfect illustration of applied anatomy.
We should also just briefly recall the other clinical nerve note mentioned earlier regarding the ulnar nerve.
Yes, just to round it out. The key points for the ulnar nerve were its palpability behind the medial epicondyle, that funny bone feeling, and the specific clinical observation mentioned in the source, that it can become palpably thickened and enlarged in patients with leprosy, Hansen's disease, which is an important diagnostic clue for that condition.
Wow. Okay. We have really navigated the complexities of the arm and cubital fossa in detail. To help solidify this mastery, this deep understanding, let's distill some absolute key takeaways from this extensive dive. What are the must-remember points?
Okay, yes. First, the fundamental organizational principle. The division of the arm into anterior, flexor, and posterior extensor compartments by the medial and lateral intermuscular septa. Recognizing these functional and anatomical divisions really structures your understanding of everything else.
Good starting point. Second, knowing the main muscles in each compartment and their key actions. The anterior compartment muscles, coracobrachialis, biceps, brachialis, primarily flex the elbow and contribute to shoulder flexion. But remember, the biceps is also a crucial strong supinator, especially when the elbow is flexed. Don't forget that action. The posterior compartment muscle, triceps, is the only powerful active extensor of the elbow. Keep those primary roles straight.
Third, tracing the complex paths and, crucially, the changing relationships of the major nerves and vessels is vital. Understanding the brachial artery's close relationship to the median and ulnar nerves as it descends, and particularly the radial nerve's winding course through the vulnerable spiral groove on the back of the humerus before it reappears laterally. Those paths are key.
Fourth, the critical anatomy of the cubital fossa. You have to know this area, its boundaries, its roof, including the bicipital honturosis, its floor, and especially its contents from medial to lateral. Repeat that, MBBR mnemonic. Median nerve, brachial artery, biceps tendon, radial nerve. Burn that order into your memory.
Fifth, appreciating the functional importance of the arterial anastomoses around the elbow joint, understanding how this network, linking brachial profunda collateral branches to radial interosseous recurrent branches, provides essential collateral blood flow, acting as a backup system for the joint and forearm.
And finally, a major clinical takeaway. Understanding the common site, spiral groove, and causes pressure fracture of radial nerve injury, the resulting classic clinical sign of wrist drop, and why wrist drop is so disabling for hand function due to loss of synergistic wrist extension.
Absolutely. Those are the pillars of understanding this region, I think. And remembering the mnemonics, the biceps origin one, shorter corner, longer superhighway, and the MBBR for the cubital fossa contents can definitely help lock in some of those specific high-yield details. Seriously, mapping out all those origins, insertions, the winding courses of nerves, the relations between arteries and nerves changing down the arm, the specific branches, it provides an incredible level of detail. It truly is amazing how much complex machinery is packed into this region of the arm.
It really shows how seemingly simple movements we perform every day, like bending our arm or turning a doorknob, rely on such intricate and precisely organized anatomical arrangements. The way a nerve pierces a specific septum, the exact relationship of an artery to a tendon, the redundancy built into the vessel network, it all contributes to the overall function and resilience of the limb. And seeing how something relatively localized, like sustained pressure on a nerve in one specific spot in the spiral groove, can lead to a significant functional deficit like wrist drop, really highlights the critical importance of these anatomical pathways and relationships.
Or how a routine procedure like measuring blood pressure relies entirely on knowing exactly where that brachial artery sits relative to the biceps tendon in the cubital fossa.
This deep dive really demonstrates that even in a part of the body we use constantly and maybe take for granted, there's immense complexity and, frankly, a beautiful logical design underpinning everything. Mastering this kind of detail isn't just academic. It's what allows healthcare professionals to truly understand function, diagnose problems accurately, and plan safe and effective interventions.
It gives you a whole new perspective on the simple act of bending your arm or turning your hand, doesn't it? You start thinking about which muscles are firing, which nerves are conducting.
Definitely. Hopefully this deep dive has provided you, our listener, with that comprehensive understanding you sought. Maybe even a feeling of beginning to master the information presented in the source material.
We certainly covered the ground laid out in that source.
So here's a final thought for you to take away and ponder, building on what we've discussed. Considering the detailed network of nerves, muscles, and vessels we've explored, particularly the vulnerability of structures like the radial nerve in the spiral groove or the contents of the cubital fossa, how might this deeper anatomical understanding influence the way we approach things like designing ergonomic tools, developing physical therapy protocols after injury, or even teaching proper technique in sports to minimize risk?
Yeah, how does knowing the blueprint change how we interact with the structure? Something to consider.
That wraps up this deep dive into the anatomy of the arm and elbow. We hope you feel significantly more informed and have a newfound appreciation for the incredible architecture packed within this vital part of your upper limb.